Okay, so we have Dr. Najim here today. Dr. Najim is going to be doing an in-service for us in regards to the maintenance of chest tubes for ground transport. And so we've got a mocked-up chest tube on Milton here, and we're going to go over some of the things to look for and to expect during transport of these.
All right, so the first thing is, yes, we're talking about a chest tube, also known as a tube thoracostomy. And a doctor may place one of these to drain air or fluid out of the pleural space around the lung. And sometimes the patients will be stable, but need to be transferred to a higher level of care. And then the appropriate way of transporting these patients is by ground. So we're going to go over all the ways, or the important aspects of transporting the patient. So first of all, when you come and assess the patient, you do normal primary assessment, gather vital signs, ask the patient if they're in pain, because sometimes chest tubes can be painful. Are you having any pain?
No.
No. Good. If they are in pain, you can ask the nurse for some more comfort and see what you might need to do during transport. Then for specifically looking at the tube, what you're going to come up to is it's going to be placed on the lateral chest, depending on which side that the air fluid had built up. You're going to see a bandage. It's going to be taped around. You want to make sure it's clean, dry, and secure. You're going to see the tube coming out. You're going to make sure the tube is secure. And then you're going to follow the tube down, checking the connections, checking for any obstructions or kinks in the line. What you want to do, though, is keep it all below the chest. You don't want the fluid to go back into the chest. And then we come to our Pleurovac or chest drain or water seal, depending on the terminology being used. It has some different areas. The first one here is the reservoir. You want to note how much fluid and what color it is when you arrive.
And that's what's come out of the patient on the chest drain side,
That'll be
correct?
any fluid that has come out of the chest drain, or fluid being pleural fluid or blood or empyema, anything that will be collected in there. You also want to see that there is water here on the water seal side. And what you also can look for are bubbles. If you see lots of bubbles coming up through here, there may be a leak somewhere down the line. Please ask the doctor to come reassess the line and make sure everything is okay. So here we have maybe a tiny ear leak, but this will be sufficient. The patient may or may not be on suction. Suction is connected up here, connected to the wall on a high level of suction. It doesn't matter what's on the wall, what matters is what it's set to here. It's usually set to -20 for adults, for kids less. Some patients are just on what we call water seal. This is fine too. The patient does not need to have suction, so they can possibly be transported the entire way just on a water seal. Our patient's on suction today.
And if they were just on water seal, Dr. Najim, would that mean that they've pretty much reinflated and we don't have any fluids that are coming out of the patient?
Yeah, so there's no more need to actively evacuate the pleural space, and they're just testing to see whether the patient builds up fluid again or builds up air again. And they'll repeat a chest x-ray after a few hours. All right, so the most important thing about the chest drain here is that we keep it below the chest and upright position. You don't want to tip it over. If you find it tipped over, immediately turn it back upright, because this is the water seal. We'll tip it over, then we're letting air get through, and air can then go back in.
Go back in, okay.
All right. And we lose that patient's ability to create negative pressure inside the chest, sucking air back into the chest. Also, when transporting a patient, you want to make sure you have slack and never kink the tube. If the tube gets kinked or clamped, any air that could build up or pressure in the chest has nowhere to go, and then eventually you can create a tension pneumo or tension hemodynamics. So we have got lots of slack, it's pretty secure, and we're keeping it below the line. Right now we have no fluid to document. The patient doesn't have any pain, he has normal vital signs. So now we can transfer the patient. Often these patients can transfer themselves over. You don't have to actively transport them. But if they need help, you can assist them. Just make sure that somebody is watching out to make sure that the tube does not get pulled. There's plenty of slack. And we're keeping this below.
And all 3 chambers on that are the reservoir for fluids coming out of the pleural space.
Yes, as it builds up, see we have 10 to 100 here, and then the increments get further apart, and these are all in milliliters going up to 2.
Okay. Now, is there a drain and or a sample port on that too, if we needed to?
There is one, but I don't think you will be doing one.
You don't think that time? Okay.
Yeah, and I'm sorry, on this example, I'm not familiar with where it is, but often there is a diaphragm where they can pull out fluid from that to test it. But on this one, I don't know if there is or not. There is a diaphragm back here for adding fluid to the water seal to make sure it's at that blue line. Again, if it's not there, just ask the floor what's going on. Why isn't the fluid in the right spot?
And if do you ever boil out water? I mean, do you ever need to add water? Would you need to do that in a 3-hour trip?
If it got spilled.
Okay, and how would we add water to that?
You would
Just a
take
syringe? Okay.
There's a needleless
Okay.
lock here you can add.
Okay.
But if you're doing everything right, keeping it upright.
Saline or sterile water is fine?
Yes.
Is that correct? Okay.
Yeah. It's not going into the patient, but it is inside the sterile line. So.
Okay.
So this model has some hooks on it for transporting. And you can hook to the side of the stretcher there, keeping it below the chest level. Just be careful when on the ambulance stretcher loading this in that pretty much dedicate a person to making sure that this does not get hooked on anything. After a while, you're going to run out of slack and you're going to pull the tube. That's going to hurt the patient, and if the tube comes out, then we have to consider if we need to place another tube or what we're going to do. We're going to talk about that in a bit. So if you don't have portable suction, it's okay to detach the patient from suction for a while. Maybe get them to the ambulance if they need to be on.
Okay.
All right. So our patient transferred over to the ambulance stretcher, suction, everything looks good. His vital signs are still stable. We load them without any incident. We're keeping everything below the chest. We're keeping it upright, and we get him in the ambulance. There is if you need to set it down on the floor, there's a foot there, so you can stand on the floor more easily without being knocked over. So, while we're transporting the patient, we want to continue to assess vital signs, especially his work of breathing and his oxygenation. Every hour you can assess how much fluid is accumulated in the reservoir. You can assess the dressing. The patient may develop acute bleeding if this dressing begins to soak, reinforce, and tape pressure. If the patient develops signs of a pneumothorax, including difficulty breathing, hypoxia, place the patient on oxygen. They may or may not be on oxygen when you transport them. If the patient starts developing signs of a tension pneumothorax, make sure you check the line here. No obstructions, no kinks. It may come to a point where you really think the patient has a tension pneumothorax, they're dropping their blood pressure, this all seems to be working adequately, have them on suction. You may need to do a needle thoracostomy. Maybe there's something, and maybe the tube is kinked on the inside of the chest. But that may be an option if the patient does develop hypotension with a highly suspected pneumothorax. Other problems you may have in root, pain. You may need to give some pain medication. Now what happens if we accidentally, or the patient flips out or something and the tube becomes pulled out? What would we do then? So if the tube becomes pulled out, you're going to see an incision here. That incision goes between the ribs and into the pleural space. You want to cover it with occlusive dressing on 3 sides. If the patient is stable, you can continue on. If you're in a reasonable amount of distance to your destination, I think you can continue on, the patient is stable to the destination. If the patient becomes unstable and does not have a chest tube, I would go to the nearest ER facility to have them assessed by an ER doc and possibly place a new chest tube.
Okay.
All right.
Don't put the old one back in? Is that what you're saying?
Yes, what I'm saying. Do not put the chest tube back into the chest.
Okay.
It is dirty, it's
dirty.
contaminated, you will cause an empyema
Okay.
and several months of antibiotics.
Okay. So along those lines, in that same instance, if he does start developing a tension again, would you recommend us doing a sterile technique of just opening that incision again?
Yes, if it's sterile, I don't know if we have sterile gloves, sterile skin, sterile instruments. Sterile glove, you may determine you can put a finger in there if you have sterile gloves. And
we're probably not going to be sterile,
So try the needle first.
Okay.
If the patient is still having problems, then the risk of death outweighs the risk of infection.
Okay.
So.
Now, do these tubes ever occlude with blood? Do they ever clot?
They can.
Do we need to flush them or try to clean them?
So some people will strip the tube, getting it out like this. This can be painful for the patient. It can cause weakness in the tube. It can cause disconnections. If the tube is clean before transport, you won't have that issue. If you do find an occlusion, you may need to strip it and break it up and remove it. It may come to the point where you may have to replace the tubing if it cannot be stripped.
Okay.
But never clamp the tubing in an effort.
Leaving the tube open is better than
than
a plug line.
Is better like this.
Yes. Okay.
So that allows any pressure built in the chest to leave.
We could use portable suction every now and again on that if we had to, right? Just hit that with, okay.
Yeah, but I think the patients that are going to be transported by ground, if you have any concerns prior to transport, talk with the doctor who's transporting the patient. If you don't feel comfortable, our friends at AirMed may be able to help and have some assistance and guidance there.
Okay.
If they put that chest tube in and it completely filled all 3 chambers, what is that, like
2,000?
2,000?
Yeah, 2,000.
Then do they need to change and put a new canister on there?
So if you notice that it's almost full before you go, yes, ask the nurse there to assess it and see if we need a new canister or this needs to be drained or what we can do about that. The patient that puts out a lot of fluid in a short amount of time will probably not be going
by ground.
So I think you're going to see a sustainable amount of output. But it's also possible that something moves and new fluid accumulation now is accessible by the tube, and you may see a lot come out at a single point in time.
Now I know some of the chest tubes have a trocar tip on them. Do you guys use those, or do you guys use the surgical technique to?
So our tip of our chest tube that we use here is
just blunt.
Okay. And soft. Often, some doctors will place it in a curved hemostat to place it in. Others will just guide it with their finger. But yes, no trocar tube.
Okay.
Unless your homie is an E-likes trocars.
Does the sharp thing stay in there afterwards? No. That's my question.
It's like a catheter. It comes out. It's a guide.
Okay. That's why I was curious if there's going to be a sharps.
No.
That wouldn't make sense, but okay.
Dr. Najim,
yes.
What is it, that little check on the front of the, you know what that means on the front of the
water seal?
Right here. When you hook it up to suction, this little white check comes out.
What is that? That is showing that we have suction on there.
What does A and B mean? I'm sorry.
A
is the amount of suction. B is that there actually is
suction present.
So
It looks
when
like
you
a
plug
little
that up to your suction,
sponge.
that bladder then
Yes.
comes forward
So
like
there's
that.
it's a
Okay. Visual confirmation, maybe.
Seems like pretty set.
This would be awful to have in between the ribs.
It can be painful, but a lot of patients tolerate them very well.
Really?
Actually, yeah, walk around.
It's preset at 20.
Yeah, it is.
Yeah.
I think the biggest thing that we risk is dumping it
Yes.
Yeah.
or dislodging. So
Like this, you don't want it to be like this, like that. So yeah, so the first thing you really want to worry about is keeping it vertical. Second thing is, or actually they're both very important, they're both 1 and 1, is that we don't pull the tube. And this, when you're loading patients, unloading patients, this is a big device. There's lots of things the ambulance would get caught on, so I would have like one person pretty much watching that to make sure it's not getting caught and we don't pull out the tube. Think about that's another painful procedure for the patient. They will likely get another chest
So I'm assuming intermediate and above is okay with this?
I think
It's
I'm
not
going to
just
verify
a grant.
that. I'm going to verify that.
I mean, 'cause an intermediate can do.
Yeah, well, if you have
Yeah, you can
complications.
transport,
Yeah.
just tubes.
Should be
Everything else
fine.
is just babysitting,
So,
you know?
yeah.
Any other questions?
Thank you, Dr. Najim.
Thank you.
Appreciate it.